Shoot, Matt, what happened out there?
I felt a big pop when I threw that pitch.
What part of the throw did you feel the pain?
Right when I was about to throw, like, oh, right there.
Okay, how's that?
It's not good.
Yeah, it does feel a little bit swollen. Let's just do the valgus test on your good side first.
That's okay.
Alright, let's check this side out.
Yeah.
Yeah, there's
Hurts
definitely quite a bit of laxity in there. I think we should just throw some ice on that. I think you might have a partial or full tear of the UCL. But we definitely need to get a doctor to check that out. I can't make the call. But let's get some ice first.
Learning objectives include 1. Discuss the functional anatomy of the UCL and the mechanism of injury. 2. Describe some of the risk factors for a UCL injury and why baseball players, specifically pitchers, are susceptible to a UCL injury. 3. Discuss the recommended treatment for each grade of UCL injury. And 4. Describe the 4 phases of conservative treatment rehabilitation for an injured UCL.
After reviewing the MRI, our high-level baseball player has been diagnosed with a Grade 2A UCL injury. Based on this knowledge, what do you think would be the most appropriate method of treatment?
The ulnar collateral ligament is the primary connective tissue responsible for providing static stabilization to the elbow against valgus stress. When the UCL is subjected to excessive valgus stress during the overhead throwing motion, specifically the late cocking and early acceleration stages, injury may occur.
Anatomy includes anterior oblique ligament, posterior oblique ligament, transverse ligament.
The anterior oblique ligament is composed of anterior or posterior bands that tighten in a reciprocal manner as the elbow is flexed and extended. The AOL bundle is the foremost contributor to valgus stability from 20 to 120 degrees of flexion. This means that it is the most stressed ligament during much of the high-force portion of a baseball pitching action. The AOL is the strongest and stiffest elbow collateral ligament. It can resist approximately 260 newtons of load or 34 newton meters of torque before failing.
Risk factors include
Signs and symptoms include
Grades of UCL injuries include
Given the current evidence, treatment options are
return to play rates following rehabilitation for grade 1 and grade 2 injuries have been found to be 93%. When looking at grade 1 injuries only, return to play rates may be as high as 100% following rehabilitation.
Phase 1 is known as the immediate motion phase. The goals of this segment are to minimize the effects of immobilization, reestablish non-painful range of motion, decrease pain and inflammation, and slow muscular atrophy. It is especially important to include flexion and extension at the elbow, as well as pronation and supination movements. The active and passive stretching movements involved will encourage the synthesis, alignment, and organization of collagen tissues in the ligament.
Phase 2 is known as the intermediate phase. The goals of this phase are to maintain and enhance elbow and upper extremity mobility, improve muscular strength and endurance, and re-establish neuromuscular control of the elbow complex. This phase is initiated when there is full throwing range of motion, minimal pain and tenderness, and a good manual muscle test of elbow flexor and extensor musculature. Since this is rehabilitation of a thrower's arm, it is important to involve shoulder flexibility as well as to avoid losing range of motion throughout the rehab process. Some strengthening exercises addressing elbow and wrist flexion and extension as well as forearm pronation and supination will be initiated. These will gradually progress from concentric to eccentric.
Phase 3 is the advanced strengthening phase. The main goals of this phase are to prepare the athlete for returning to sport-specific activity by gradually increasing strength, power, endurance, and neuromuscular control of the elbow complex and arm as a whole. To initiate this phase, the athlete must have full non-painful throwing range of motion and must not exhibit any pain or tenderness in the area. They must also have strength in the injured elbow that is at least equal to 70% of the contralateral arm. Phase 3 will include exercises from programs known as the Throwers 10, with a greater emphasis on eccentric and plyometric exercises. These exercise programs will be described in greater detail shortly.
Phase 4 is simply the return to activity phase. During this phase, the goal is to progressively return to full competition through interval training. Typically, this will include a long toss program, which will gradually increase throwing distance from 45 to 180 feet, thus increasing the stress on the elbow. Following the successful completion of this program, the athlete should be able to return to competition.
As mentioned previously during Phase 3, the Throwers 10 exercise regime is a beneficial aspect of the 4-phase rehabilitation program. These exercise activities address strength, dynamic ability, and proprioception, as well as promote the type of high-level endurance required to facilitate an athlete's return to a high-demand, repetition-based sporting activity such as pitching. An athlete is typically instructed to perform 10 repetitions of each movement pattern for all exercises outlined.
Grab some equipment and follow along.
Complete UCL tears were considered career-ending injuries until Dr. Frank Jobe performed the first successful UCL reconstruction in 1974. This technique involved bone tunnels and a figure-8 graft. It enabled only 63% of throwing athletes to return to the pre-injury level of sport. Furthermore, 31% of these athletes experienced complications.
This led to a number of different surgical techniques being tested over the years, the first being muscle splitting, which avoids detachment of the flexor pronator mass and instead involves a muscle split through the common flexor tendon. Return to play rates for this type of surgery were found to be 82%. Complication rates for these players was 8.4%.
The suture anchor method appeared successful in cadaveric studies. However, when introduced to clinical trials, it yielded a failure rate of 30% and was terminated. The docking technique was developed due to the high rates of ulnar neuropraxia and medial epicondyle fractures associated with the Jobe technique. Instead of a figure-8 position, the graft is placed in a triangular configuration. This technique has the highest return to pre-injury level of play rates, which have been found to be 97%. The Dane TJ technique involves a combination of the docking and interference screw techniques. It has been shown to lead to return to play rates of 86%, but also has a 17% complication rate.
After hearing this information, what do you recommend for our baseball player? Remember, he has a grade 2A UCL injury.
Now imagine the athlete has a grade 1 injury. Would your recommended treatment change? Now imagine the athlete has a grade 3 injury. Would your recommended treatment change?
To summarize, the grade of the UCL injury can often be used to determine the need for surgery and return to play rates. Often, partial UCL tears can be treated successfully with rehabilitation, such as the 4-phase rehabilitation program. Generally, surgery is recommended for the individuals with complete UCL tears or partial UCL tears that have failed rehabilitation.
Thanks for watching!